your opportunity for these folks, and you should have sharing options as well.
Excellent. Thank you so much, Alice. And I will share right now. Hopefully everyone can see my screen. Um, yeah, hi everyone. I just wanted to pop in quickly here and share a little bit about Vital Interaction. My name is Ty Yeager. I'm a director of sales here at Vital Interaction. I've been supporting the safety net for, gosh, going on 5 years now. And so always studying what's out there in the patient communication space, how we can best support FQHCs and community health centers in general. And would love to also introduce my teammate, Allison here. Allison?
Yeah, hi folks. You kind of got the snippet of my background there. But yeah, I've been working with Vital Interaction because they really had a sincere interest in aligning with community health centers and the mission behind it and supporting the patients that you all and everybody across the country and territory serves. And so, working with them in the last year, we've been able to really engage patients in a meaningful way. And I know we don't have a lot of time, so I'm going to make sure I allot a lot of it to Ty to run through things. And I'll probably sneak a few comments in here and there as we go through, but always afterwards and post call, happy to answer any questions you may have.
Absolutely. And please do, Allison. Thank you so much. So Vital Interaction works with FQHCs across the country, three of them being in Kansas. We just recently partnered with another new FQHC at the end of last month. So we're really excited for the traction we have in your state and knowing the impact that we can support your staff and patients with. So just to quickly set the stage a little bit, Vital Interaction is a patient communication platform that really supports reducing no-show rates and cancellations, making sure those patients are going into the appointments that they scheduled, improving outcomes and closing care gaps, helping with those UDS metrics, and really increasing visit volume overall. That's one of our specialties. And then, of course, in a time that we really are tasked with a lot of different items and so much going on, also easing that staff workload through smart automation, which I'll share a little bit more about. Very quickly, I'll kind of, when I think of patient communication and how it's been over the past few years, there's emails or texts through the EHR, robocalls, which work to some extent. You might still have patients coming in, but Vital Interaction really reimagines the way that communication can look, leveraging the voice of a provider to send out outbound provider recorded phone calls, videos, pre and post appointments, especially for care gaps, educating them why they're scheduled for that respective care gap or why they should come in, or potentially even post appointment when patients newly diagnosed with a chronic condition. They may have been overwhelmed in the visit and need that education post visit to really live a healthy, balanced lifestyle. Also excited to share one of our proprietary tools in our AI enhanced videos as well. So how kind of maybe a zoomed out view of how Vital Interaction supports FQHCs is we will automatically pull information from your EHR. I know a lot of folks are on Athena or ECW, NextGen. We work with just about every practice management system EHR out there to extract information like demographic, age, race, sex, ethnicity, gender, patients who are due for a respective screening or lab, or also those who have missed their appointments and have not yet rescheduled. We can get really granular, pulling insurance types, clinical codes to what we ultimately will do, then prioritize those use cases. Maybe at the top, we have patients who have no-showed or canceled in the medical department or behavioral health, and we need to get them back in. Or even prioritizing folks who are on Medicaid or Medicare or uninsured. With the information we're extracting, we can really have that our smart list engine is what we call it to prioritize those use cases. I've even seen maybe lower on the priority list, happy birthday messages or something more, to build that relationship for patients. And then all of that communication is going out without scrubbing the charts for who's due for what or uploading CSV files. Vital Interaction does that automatically. So through our integration with your health record system and your practice management system, we're able to automatically send those communications out to drive down no-show rates, increase encounters, and really strengthen that entire continuity of care. So what I'll do here is share what our AI enhanced videos look like. So this would be the likeness, the voice, the face of the provider that patient would be seeing. Ultimately, they would record one quick video one time, and then we're able to scale that across any use case. So this is an annual wellness visit, but without having to re-record, we could scale this to cancer screenings or A1C labs, hypertension, and so on.
I hope you're doing well. I wanted to reach out because I noticed it's been a while since we've had you in for your annual wellness visit, and I want to make sure we're staying on top of your health. Your annual visit is more than just a checkup. It's a chance for us to look at the full picture of your health, catch any early issues, and talk about anything on your mind. I know life gets busy, but these visits are important, and I'm here to support you however I can. The visit is fully covered by insurance, so there's no cost to you. To schedule, give us a call at 555-1212 or visit healthywaysmedical.com/schedule to book online. I look forward to seeing you soon.
Yeah, so that is a great way where patients are receiving a personalized message from their provider, someone they trust and know, which ultimately we've seen drives response rates up about 3 times compared to traditional texts.
Some of the health centers that we've been working with too have managed to leverage these videos. With some providers are okay with it, others are like, let's see how this goes. But some have used it in order to draw particular kinds of patients to a service that is being underutilized. So, for example, one health center we're working with has a good size PT/OT offering in their community, but it's just not getting leveraged and utilized enough. So they recorded videos for their PT providers and begin to start to use that piece of communication out to the medical side of their patients to draw some of those patients in. And similarly, another health center has done that with their dental service, where they had a lot of dental patients, but they weren't necessarily coming into the medical side. So they're outreaching in that way to say, hey, we're here for your medical needs and annual wellness visits as well. So there's a lot of different kinds of use cases, because we know health centers have all different kinds of populations and needs in their community. And there's different ways to be able to fine tune things and bring those patients in.
Amazing. Thank you, Allison. And so I know we just have a short window today. If we are interested in learning more about Vital Interaction, we can definitely talk about all the different functionality we have. But from my perspective, I know data really can speak volumes when it comes to how we support FQHCs. And so 2 of the things I mentioned were Vital Interaction can reduce no-show rates and cancellation rates, but also increase encounters. And so I'll share 2 quick examples, one of them being Midstate Health. As you can see, they had about a 7.5% no-show rate before using Vital Interaction. A pretty good no-show rate, all things considered. That's why we chose a challenging one. But we were able to reduce that by 24%. So almost a quarter of those patients who were missing appointments are now coming in for their appointment using our custom contact card, those AI enhanced videos, and more personalized messaging that would be difficult if you're doing it in a more manual basis. Now, since we're automatically reaching out through really in a set it and forget it fashion when a patient cancels or no-shows, or those care gaps that we're prioritizing, those messages are going out without having to type it out and send those out to patients. Therefore, we were able to increase encounters by about 30%. So for this 33 provider health center, that translated to about 1,700 additional visits monthly. Similarly, we work with Edward M. Kennedy, another FQHC. They were really focused on increasing encounters. So they chose just 5 use cases. Let's see how it works. How many more patients can we bring into the clinic? And ultimately, using no-show medical, cancel medical, hypertension, diabetes, and well child visits, they were able to increase not just schedules or appointments scheduled, but also appointments attended. Almost about 1,749 more patients were brought back into care that were not, it wasn't prioritized in their health journey. They were missing appointments or idle in the system. And so we're able to bring those back in, and ultimately between, on the lowest end, almost a 28% increase, but for no-show and canceled appointments, we're able to bring in almost half of those patients. So all through automation in a hyper-personalized way without having to pick up the phone and call or send manual text messages out. And so that's just about the time we have today. I did want to show you one of our newest features, though, that I think is pretty incredible. I don't know any other functionality like this in the space. And I know it varies from health center to health center if patients primarily speak English or Spanish or additional languages. But what Vital Interaction can do is maybe your staff aren't speaking the same language as the patient. Well, that's no longer a challenge. We're able to send out a message in a one-to-one fashion. We can type out that message, and based on the language in the patient profile, we can send that language or that message out in that patient's preferred language. And then when they message back in that language, we're able to actually receive that in English. So there's that bidirectional translation that we're able to really communicate with patients in a one-to-one fashion. So, Allison, did you have anything else? Otherwise, that would cover our time here for the most part.
No, you tore through that pretty well. I appreciate it. But yeah, to your point, there are other pieces of functionality that health centers are leveraging in order to improve the KPIs that are important to them in their journey, whether it's a grant, UDS reporting, VBC, whatever the area of focus is. That's probably a nice little segue for VBC stuff, but it's that customizable that we can be able to create those kinds of campaigns that are truly engaging to the patients. And so, happy to chat more with anyone who has any interest.
Great.
Yeah, and I'll
Both.
finish.
Yeah.
I'll just finish by saying, so we have a few discount offers for Kansas Health Centers that I want to call out. First, to even get the conversation started, any folks who would be interested in scheduling the demo, you can scan this QR code on the screen. We'll get you a free gift card just for seeing what Vital Interaction is all about. Of course, no pressure to move forward, but should you decide to move forward like the other FQH, the other three that we work with in Kansas, we do have some special opportunities to both discount and maybe some other performance guarantees that I could talk about. So looking forward to having a conversation, and Alice and the whole team, I really appreciate you for allowing us to be here.
Great. Well, thank you, Ty. We do have just a couple minutes, so if anybody has any questions they'd like to ask while we have Ty and Allison, now is the time to either say it out loud or put it in the chat.
Yes, please. Happy to answer any questions.
How does this work with ECW? You had mentioned that you have 3 folks in Kansas that are using it. Are they using ECW, and how is this working together?
Yeah. So one of our FQHC partners utilizes ECW. They're about to go live very soon. So it would work in that fashion of how I described our smart list engine. We extract information right from ECW, know which priority appointments we're trying to schedule or reschedule, and then ultimately sending those messages out on an automated basis. Does that answer your question, or any follow-ups?
Oh, no, thank you. I appreciate that.
Of course.
Thanks, Lori. Anybody else? All right. Well, thank you both for joining us today. Hopefully you've had a chance to scan the QR code before we change the screen here. And if you don't, these slides will be shared, so you'll have access to them as well after the meeting. So thank you again for joining us, and I'm sure we'll talk again soon.
Absolutely. Thanks so much, Alice. Thank you, everyone. Hope you have a great day.
Thanks. All right. So we're now going to transition over to a little value-based care discussion. Terry has been working on pulling some materials together to just try to help identify just what are all the opportunities that are available, because there's just a few of them. And so we want to make sure you know about them all. But she has dropped into the chat a couple of documents. These two will also get emailed out to you as well. But Terry's going to take a few minutes just to kind of talk through the materials and what's available. So thanks, Terry.
Thanks, Alice. Okay, so I said earlier, I'm the director of the HCCN program here at Community Care. Our HCCN project is funded by HRSA, very similarly to how our PCA receives funding from HRSA. We have 18 of the 21 health centers in the state participating in our HCCN. One of the objectives of the current HCCN project, which we're just about to wrap up our first year of a 3-year project, is advancing value-based care. The last few projects have actually been focused on preparing health centers for value-based care, and so this one is really kind of stepping into, okay, now that you're prepared, let's get some traction on that. So one of our activities in that objective is to explore the different value-based care opportunities available to our members. When I first went into this activity, I had this, global view of I'm going to find out all these different opportunities for all these different programs, and I quickly discovered that I really needed to narrow it down just to the Medicaid opportunities that are available to us, because there are so many payers that I really didn't think about in the very beginning. But so what I did to complete this activity is I started by talking with health centers to find out, what are you participating in? I discovered along the way that there are times when health centers don't necessarily know all the things that they're participating in, and whether or not that was just the person that I was talking to, or that other people know, but there didn't seem to be a global view of all the different opportunities in every health center. Some health centers have that their matrices and all their opportunities down pat, but so I did start with interviewing health centers. The next thing I did was I met with representatives from our MCOs and gathered documents, had conversations with them about their options for value-based care, gathered documents, and then I just scrutinized those documents to try and figure out all the different components. And so the two documents that I put in chat, one of them is it's a very brief document that shares some of the things I found out about Medicare, Medicare Advantage, and other options. And then the second is the Medicaid options, and I feel like that's a pretty complete document. So in the next few minutes, what I'd like to do is just give you an overview of the key factors from those opportunities. And as I'm going along, feel free to interrupt me if you have any questions, or you can keep your questions to the end. So Carrie, next slide. All right, so my primary goal, as I said before, was to identify, after I kind of narrowed my focus, was to look at all the Medicaid option. But I was able to get some of the information for Medicare and MA. I didn't dig into, in your document, I listed the ACOs that I know of that our health centers are participating in. And I give you, there's links in those documents that you can go to their site to see who the participants are, and then a little bit of information about the ACO. I did not dig into the quality measures for each one of those programs. There's some legal issues with sharing contractual information, and I just didn't want to necessarily even try to go into that. So the folks that are participating, obviously, they know what those quality measures are. For the Medicare Advantage products, what you'll notice is those are what's available from our MCO parent companies. So I didn't reach out to Blue Cross Blue Shield of Kansas. I didn't reach out to Blue Cross Blue Shield of Kansas City or any of the other different payers that your patients have for their insurance. So these are just a few of the opportunities that I found from Centene and UHC. It's a very incomplete list, but I think what it does demonstrate a little bit is that there's a differences in eligibility to participate in the program. Centene and Sunflower they take the approach that you're participating until you tell us you don't want to. So you are automatically opted in if you have a patient that has well care and you haven't told Centene you want to opt out of that program. They're considering you participating. UHC is very much contractual letter of agreement. They're not going to let you participate until you tell them you're going to participate. So it's just a little bit of a different approach. Oh, Carrie you moved on to the next one. Hold on a second, Carrie. There you go. The other thing that I wanted to point out is that the payment models vary. So some of them are basically if you complete a task, you get paid. Some of them are per member per month. Some of them are an annual bonus that you get for participating and completing some of the measures of focus. So now next slide, Carrie. Okay, this is the meat of what I wanted to talk about. Medicaid. You'll notice this document has, I think there's 4 pages, 3 MCOs, 4 pages, and there's also the pediatric care network in there as well. But there are a lot of different opportunities for participation in value-based care programs from just 3 MCOs. And I talked about Sunflower and UHC and their eligibility approach. It's the same whether you're in Medicare, MA, Medicaid, anything that they offer. Healthy Blue is really only Medicaid, so I didn't. There's nothing in the Medicare or the Medicare Advantage from them. Their parent company would have opportunities, but they're not going to because they are just a Medicaid MCO. They do require a contract or letter of agreement, just like UHC does. So they're not going to participate. You're not going to participate in their program unless you sign a letter of agreement. Sunflower, you're in all of these unless you tell them you don't want to be. As we were going through these programs, one of the things that came to light for me was that there's a very little alignment of quality measures across the MCOs. And many of the programs don't even focus on quality measures. They focus on either utilization measures, access measures, or the completion of a specific task, giving them information such as they have one of them has a pregnancy initiative where they want you to submit a document and fill out a form every time you get a pregnant patient. So that's how you get paid for that opportunity. And basically there's no risk involved in these because you either participate or you don't. And if you submit those forms, you get paid. If you don't submit those forms, there's no risk there. You don't get a ding for not doing that. Again, the payment models vary. So you can see that in that column of the document. And the thing that I found really interesting is that you can participate in not only multiple opportunities from the multiple payers, but you can participate in multiple opportunities from the same payer. So from Centene or Sunflower, you may be participating in 6 different opportunities, and that's okay because they don't overlap. There are a few that they will tell you, no, you can do this one or that one. But for the most part, you can participate in all of them if you want to participate in all of them. One example is Healthy Blue had a provider quality incentive program and a provider, they call it PQIP, and they also had PQIP Essentials. You can't participate in both. One of them is shared savings, one of them is pay for performance, and you had to pick one or the other. They've actually taken the PQIP program off the table for right now, but we could potentially see that coming back in 27. So one of the things that I included on here was the Children's Mercy Pediatric Care Network, which they just call the PCN. That really focuses on the Kansas City area. And I do think that the health centers that are eligible and that have patients that are in that area are already participating in that program. Centene pulled out of that program starting, I think, May 1st. So going forward, it's going to be Healthy Blue and UHC only, patients only. And I did not, again, delve into what the quality measures of that program are. So it's just the basic information about that program that's in this sheet. Okay, Carrie, next slide. So this is my final slide, and this is sort of an offer for you all. We've taken all these Medicaid programs and we developed this measure matrix that says these measures are in the programs. Knowing that if you have a measure that's in 5 different programs and you're participating in all of those, that may be something that you want to focus on, that measure being successful in all of those programs. However, sometimes you get more money by participating in a program with a separate measure. So the offer is that we could take this for anyone who's participating in the HCCN, and I think all of you are. We can take this document and help you build one that's specific to your health center. This document is based on 2 different documents. One is from Azara. We did this for UDS and just the different UDS type alignment programs, MIPS, and those kind of things several years ago. So I used that document, and then Amy Seeloff from Heartland shared their measure matrix with me. So I just sort of combined those and put those together to create this. So if you would like to work with us, we're happy to do that with you. You just need to contact me, and I will put my email address in the chat. One of the things I did before I close, one of the things I wanted to let you know is that I stated earlier that, oh, thank you, Alice, that the prior HCCM projects have been about preparing for value-based care. So especially in this project, one of the things we've been trying to do is to shore up the systems behind the scenes to work for value-based care. And the differences there are, we, for years, have been focused on UDS, and UDS is only our patients. Value-based care are our attributed members, and so they're not necessarily our patients. They're our patients plus. So value-based care looks at all of that population. And so we have been trying to behind the scenes. The other difference, I'm sorry, I got to back up. The other difference is we report UDS to HRSA. Your value-based care performance is all determined by the payer, and the information that the payer knows is what is what's going to base your performance. So it's vital that your systems provide that information to the payer. So the things that we've been doing behind the scenes is setting up systems like your clinical rules engine and setting up the HIEs with like your QHINs so that you can get that information to the payers and from the payers so that you've got the best picture of your patients for them so that you can get the credit for the work that you're doing. And that's including your HCC coding, your all of that risk and diagnoses that they use to determine your patient's risk. So if you want any help with that, again, you can contact me. We are in the process of developing a data dictionary. That's a coding data dictionary that kind of goes through all the different codes used for different measures, for different visits, for different, all of that. And you can probably guess who's putting that together, Maria. I believe that it's supposed to be ready in May, and I believe she's going to introduce that at the next RCM roundtable. And I think we'll probably be putting that on our website as well as a resource. So with that, I will close and hand it back to Alice, unless there are any questions.
Thank you, Terry.
You bet.
Can I ask one question real quick?
Yes.
Sure.
And just because I don't know my own ignorance, but who attends the revenue cycle roundtables?
Oh, it's a good question. I'm going to look at Marina because you're the one who usually knows who gets invited to those things.
A lot of the people that get invited to that meeting is the kind of like your billing and coding staff. Anybody who deals with revenue cycle management. I believe that some of the CFOs are invited, if not all of the CFOs as well. And then, of course, if somebody at your organization gets an invite, they're welcome to forward that on to anybody else as well.
I was just curious.
Yeah.
A lot of times as operations officer, and I mean, I'm an open book. So like I'm a nurse by trade, but coming from a hospital to an FQHC, I have a lot of questions. And so that's why I'm asking.
Yeah.
Is that something that you want to be invited to? Because I can add you to that invite if you'd like.
Oh, I would love to.
Okay.
Yeah, I can tell you, Lori, just from looking at the list from the last meeting, the people that were invited from SEK were Susan Waldman, Lori Lowry, Teresa Harris, Megan Graham, Rhonda Clefman, and Ashley Aviles. Now, that's not to say they all attended. I didn't look at the attendance list, but that's
they
the
are
group.
all,
Yep.
yes, ma'am. They're all revenue cycle and finance. And I
Yeah.
totally understand that.
Yeah.
Maybe I just need the cliff notes for understanding so I don't have to ask so many questions.
Questions are good, though. Questions are good.